Welcome to the clinical cookout. You know you need it, it's kinda scary, but mental health is necessary. Four educated queens taking the lead, hold their hands and they'll help you succeed. Lay your head back, relax, just like that. Now listen to, learn, and your problems will burn away. Cookout, you know, we got just what you need. At the cookout, your heart and mind we will be. At the cookout.
This podcast is for educational purposes only. We are qualified clinicians who will cover various topics on mental health and will sometimes provide community resources. We are not being paid by any organization for our content, and any information we provide is general and pertains to our own personal experiences. We do not provide psychotherapy, diagnoses, or treatment recommendations on air. Any concerns related to your individual mental health should be directed to your medical and mental health professionals. We are not responsible for others' decisions or the subsequent consequences.
Guess what, y'all? The in-person clinical cookout is coming to a city near you, and that city specifically is Cleveland, Ohio, on July 13th, 2024. So get your tickets, get registered, and we'll see you there.
Yes, and we are doing a mental health conference, and we are doing a clinical cookout. So you don't want to miss either. The mental health conference, we are all presenting as the Aunties. I'm talking about psychological evaluation, what that looks like for the minority community.
Auntie Keisha is going to be talking about how do we reach our kids in a way that's good for both the parent and the child.
Auntie Sugar is going to be talking about trauma. Y'all know I love trauma. Let's talk about our childhood trauma. Let's talk about how we pick all our trauma up and bring them into these relationships. And that's relationships with your kids, your spouse, your family, your friends, your church members, everything. Let's unpack our stuff so that we're not dumping it all over everybody else.
And Auntie Ashley is going to be talking about all those relationships Auntie Shug just mentioned, but from a womanist lens, and how we can better our relationships if we take some things from that frame. Don't forget to tell people now. Y'all, it's free. There is no excuse. The registration is free. You're gonna get free food and free mental health. So come on. Oh, and just know, if you by chance cannot make it out to Cleveland for the in-person clinical cookout, but you still want to support the clinical cookout in order for us to help support the community, you can always donate. We have a donation button available on our website, and you can go and click on it and just pour your money into something positive.
Hey y'all, so the aunties know there are tons of card games out there, but none quite like this. Auntie Ashley wants to know, in what ways have you been the villain in someone's story? Auntie Shug wants to know, what is your biggest insecurity about your body and why? Auntie Keish said, if you could complete a greatest hits album with all the songs that lift your mood, what would it be? And Auntie Amber is wondering, when have you put on a mask to conceal your feelings, and how did this affect you long and short term? Our new clinical cookout conversation cards are meant to be a fun, interactive game that helps to deepen your relationships with family, partners, and friends. And with that objective, everybody wins. Pre-order for the clinical cookout conversation cards is available now. So go on and get you some for your next cookout.
At the cookout, you know, we got just what you need. At the cookout, your heart and mind we will be.
All right, y'all. So for our main dish today, we are going to be discussing bias, specifically racial bias in the medical field and the mental health field. And I have a very special guest that I wanted to have for this episode, because I went to Xavier University. So I know some Black doctors, okay? I have quite a few friends that are Black doctors. And this particular person I felt would be best for it. So I want to bring her on now, and she can introduce herself so that we can get going.
Hey, everybody. I'm Dr. Emmary Butler. I'm a board certified OBGYN. I've been practicing for about 8 years now, 6 years in private practice, and now 2 years as an OB hospitalist. So a little pivot in my career. I now handle a lot of OB emergencies and GYN emergencies instead of seeing patients in the office. And I'm very glad to be here to discuss a hot topic. So let's do it.
Right. So who got their first question ready to go for this topic of racial bias in medicine and mental health? Because we know we all have seen it.
Well, Ash, can you actually talk a little bit about why? Because you were the one that brought this topic to us, and why you brought this topic to us. 'Cause I think there was a specific situation, but like just in general, what was your reason for wanting to discuss this?
So in general, I've always been like really adamant about how cultural competency does not actually happen in these fields. Like we get training in it, they swear that they teach it, and we don't actually see it. So that's always been a big deal to me. But specific things, it's been a lot of very specific cases that have come up on social media regarding this. There was a very big influencer, a young woman, a Black woman, who passed away recently because she got misdiagnosed several times as just having fibroids when in fact she had, I think, ovarian cancer or cervical cancer. Yeah, cervical cancer. And she died because they caught the cervical cancer too late after all the misdiagnosis. And part of it is because when I heard that, I was like, so many doctors automatically assume Black women just have fibroids. That's it. All you got is fibroids, when it could be something else. And then there's been several other cases of things happening specifically to Black women when it comes to childbirth and labor that just had me like, how much is this happening? And it's not even just like some people look at it like, oh, it's just like regular Black women. This don't happen to rich Black women. No, Serena Williams had a problem during childbirth, and they didn't believe her when she said she was in pain, and she had to literally fight to get them to check her. So it's just something that resonates with me as a Black woman, as a Black person, and then reading statistics that say, well, bias in medicine has always been a thing. Like based off of history in this country, y'all were experimented on. Like things like that, just that's I'm very passionate about. So I really wanted to discuss this openly.
I wanted to say something too. When I was pregnant with my first daughter, Tamia, I had went to I had two stillbirths. So this pregnancy was like particularly hard. A lot of times I probably could have been tripping a lot of times because I was just thinking like, she's not moving. And sometimes she probably was moving, but in my head, I had already been through it so much that I was thinking, she's not moving. What's going on? So I actually went in there and it turns out that she wasn't moving as much. And I had lost two of them from IUGR, intrauterine growth restriction. But this time they said, okay, she's not moving as much. So I ended up staying in the hospital for a few days, I think 5 days. And I just had to stay on like the non-stress test machine. Well, I had an Indian doctor. And I mean, I felt dismissed by them at least more than once. And like I had an Indian doctor come in and he said, "You're fine. My sister went through this. It's just probably in your head." And I cussed him out. And then I ended up saying, like, I don't want you. I don't want to see you again. I want my doctor. So my doctor was Scottish. She was actually visiting Scotland at the time, but she came back within a day. And then it turns out she did look at me and baby did stop thriving and we did have to hurry up and get her out. So he ended up coming in the like in the NICU. We call it special care over there in England, but he ended up coming in special care. And even when he was like, okay, wow, I said, I told you, I knew what I felt. He just kind of, it was very dismissive. I did feel dismissed.
Now, unfortunately, that's very common stories. Exactly what you said. You can't just dismiss somebody's concern just because you've seen it again, or you've seen it in the past. And that's patients' biggest concern and biggest complaint right now is that they don't feel like they're being heard, or that their concerns are being addressed, and that they're being dismissed. So then that builds on the distrust of healthcare. So I hear it all the time, even within my family. My own father, he's like, I don't want to go to the hospital because they're not going to do anything. So I'll just stay at home and figure it out myself. I'll look it up, or I'll take Tylenol, drink water, and it'll just go away, because essentially, that's what they'll tell me in the hospital. But a couple months later, I'm also getting this huge bill of, I'm thinking that nothing was actually done. So it's a very sad story. And, unfortunately, the doctor that you initially seen and showed was wrong, and your doctor thankfully was right and acted on, her gut and what was right. And he never apologized. And sometimes, just acknowledging that you were wrong and learning from that experience, I feel like that is what, as a culture, as far as us in healthcare, is going to take us to the next level is, admitting that we're human, we're going to make mistakes. We may miss a thing or two, but just putting it in your head that but I'll never dismiss, a patient that comes in and says that they have decreased fetal movement. I'll never compare your situation to a situation I've seen before, and I'll do better. But people aren't doing that, and that's the issue.
Speaking of people, sorry. I was going to say, speaking of people not doing that, one of my questions, well, I guess double question was, what are the biases that you typically see, as a medical doctor or OGBYN toward African Americans? And as well, what have you seen or heard during as a student, when you were a student, like what type of things were they teaching you that you might have been like, I don't really know if that's true, or may have, just it kind of a light bulb went off, like this is kind of a bias that continues to go on, and that we probably need to address.
So I would say, as a healthcare professional now, the biggest thing that I see and the most common complaint is that people aren't being heard, and their concerns aren't being addressed. And so they don't trust. And I think at baseline, a lot of minorities, especially African Americans, like Auntie actually mentioned, these things, as far as us being experimented on, goes way back in the day. I realized, who they call the father of gynecology, Dr. Sims, was experimenting on enslaved women without anesthesia. So some of the procedures that I'm thankful that I'm able to perform, it just breaks my heart to know that, women who could have been women from my family that look exactly like me were experimented on so that I can do these things today. So it's almost being, between a rock and a hard place, because it's just really sad. I would say as a student, unfortunately, like Auntie actually said, people are saying that, we're teaching diversity, we are teaching inclusion, but are we really? So, you do 4 years of medical school, and I would say I could probably remember 2 lectures, maybe during Black History Month, that they may have addressed, culture or diversity, but it was something that was very superficial, that was just glazed over, just so they can essentially check a box and say, okay, yep, we've done that. We put that part of your criteria. But, the biggest things, and some things that I'm seeing now, is that, they never taught us how do disease processes show up in minority patients. How do rashes look on Black skin? You have no idea. So when these patients come to you as a primary care physician or as a physician in the ER, and we're presenting differently, it doesn't mean that we're wrong or, that we're making it up. It's just that it's different, and that those things aren't taught. So it's like, okay, whose fault is it? Is it, the school's fault for not filling that gap and actually teaching us the broader, scheme of things? Is it our fault for not actually seeking out that extra knowledge? But I would say, once again, when you see these things that are different, to actually learn from it, instead of saying this is made up, or, this isn't what I was taught in the book. Because honestly, as y'all know, everything is not going to present in the book. Patients aren't reading the definition of diagnoses and coming in and telling you, okay, here are the criteria. I'm meeting these criteria so that you can make the diagnosis. They are coming in and telling you the things that they're feeling. And you have to put those pieces together and make, the appropriate diagnosis or the appropriate treatment. And I just feel like people aren't thinking outside of that box and learning from the things that, we're seeing every day, very commonly, over and over again.
You know what? That's actually something similar. We can all kind of assess that being a similar thing in mental health. Depression shows up totally different a lot of times for Black women and Black men in different cultures. It shows up very different. So our books don't necessarily say this is how depression shows up for a Black woman. It doesn't say that. So we see these criteria in the DSM, and it's like, yeah, but she not meeting those criteria. So does that mean she not depressed, or does that mean it just looks different? So it's not even in the literature. It's not even in the research. Like you mentioned the whole rashes showing up on black skin, and I thought about my daughter. My youngest daughter has eczema, right? But there was a point when she was young where she had this rash, and my aunt, who works in the hospital, had worked in the hospital for over 20 years, she said, "Oh, that, but it don't look like that on white skin. So when you take them, you tell them that you think that that's what it is." And I took her, and they were like, "No, it doesn't look like that." I said, "Well, her skin is black. It doesn't look like that on white skin." And they were like, "Okay, well, it might be." And they gave her the proper, I can't even remember. She was like 4. They gave her the proper medication for that diagnosis, and it cleared up. But had my aunt not told me that, all I would have knew was, well, it ain't that. Like, they don't know what it is.
I had a patient and we did talk about depression, but she was so high functioning. So like she's doing everything for her family. She's showing up in places like for her family, for herself, at work, being a caretaker. Sad, depressed, just wants to lay in the bed, but she didn't recognize it as depression because she's like, nah, but I'm doing all this stuff. I'm getting all this stuff done. I'm just extra tired at the end of the day. So I had to actually tell her, like, sis, that's what depression looks like in Black women because we have superwoman syndrome. Nobody else is coming. It's up to us. Like, so we got to get it done. And so, like, I almost had to convince her, but then I had to say, I'm not here to convince you that you have depression. I'm just here to make you aware. But there was a large sense of denial. Do you have a problem like with people that are in denial? Because Black people don't like diagnosis of no sort.
Oh, absolutely. Or you're fighting against like what their mom or their grandmother or social media or their best friend have told them. And I'm really big on one, educating the patient as far as like, okay, these are the things that I think it could potentially be and what we're going to do about that. And I feel like a lot of providers don't take the time because we don't feel like we have the time all the time. Like a lot of organizations are pushing numbers. And so you got to see however many patients in a day. So you got 5 minutes to see this patient. Like, do I have time to sit down and totally explain this? Probably not always, but that's something that I'm like huge on. But I educate them just so they can make the best decision as far as their treatment. Cause I tell them we're a team. Like you're not against me. I'm not against you. Like I want whatever we decide on today, I want both of us to be comfortable with this decision. And some patients aren't. And it's like, well, I saw on social media that, X, Y, and Z. And the issue is there's so much misinformation out right now. And there's a thin line between advocating for yourself. And I'm like, I'm all about standing up for yourself. But then there's also another side where you're actually interfering with your health. And that's the tug of war, especially in my field, being in OBGYN, especially with OB, I'm dealing with a mom and a baby. So sometimes I'm making the best decision to have a better outcome for your child and also to keep you safe, but you don't agree with it because you've seen X, Y, and Z on social media. And I'm like, okay, you could potentially die. Like sometimes you have to use those hard words so they really understand, like, this is what I'm concerned about and this is what's going on. I'm not just doing this for fun, but it's a tug of war. And, honestly, because I'm in the field and I know a lot about it, I can't always relate to like how they're processing things. And I kind of stop and I'm like, okay, what is your concern? Like, why are you saying no? Or why aren't you comfortable with this? Like, what is your concern? Or do you need time to think about it and talk to your family? So they don't feel rushed into, one decision or another. So it's tough. It's playing tug of war for sure, especially, with what we've learned and with social media, like, because you can probably look up, if you had the belief that the sky was green, I probably could Google something and it'd be a group of people that would support, like, yep, the sky is green. So, if you have a certain belief of, whatever in medicine, I'm sure you could Google it and it will support your thoughts. And that's exactly what we're fighting against right now.
Yeah, that's called confirmation bias, where you're looking for the information and you're finding only the information that supports what you believe, but all the other stuff you ignore.
We really appreciate you kind of saying, about the misinformation, because I think that we also go through the same thing as mental health professionals, that everybody is getting their sources or getting their information from people who literally don't have a degree in
Yeah.
mental health at all. And so we're battling up against that a lot. And so have you guys maybe within your own practice, or maybe even with medical school, have now this new age of technology? Is there any efforts being put toward addressing some of the misinformation or disinformation that's out there? Maybe there isn't, but I didn't know if there was something maybe new coming out to help address that.
I mean, honestly, not to my knowledge. And I mean, just thinking how big the internet is, like we will be fighting against giants all day, every day. And, I don't know if it's the same for you all as far as when people say research, I'm like, okay, what's your source? Because I know the sources that I use, we actually have to pay for it and be members of. So, the general public don't have access to like the actual literature. So in my office, I would print off all the most common things that I would see. And then I would give those handouts like, okay, if you want to make decisions, like at least use these resources. Because at the end of the articles, it has all the sites as far as like that they used as well. I'm like, you can use any of these sites. If you don't have access, I'll get you access if you want this other article. But like, please use like concrete resources to make
Yes.
decisions and not like made up stuff.
Yes. A lot of people love so whenever we like doing like the diagnosis and stuff like that, or if I give somebody a diagnosis, I say, don't go to Dr. Google.
Please.
Let me go ahead and give you peer-reviewed, evidence-based research today, because you can Google anything and then people just put anything out there and people are like, oh, this has to be from the Medical Technical Institute. And it's like, who is that institute? I don't know them.
Nobody.
So after we graduated, we still have like access to the library and stuff like that. So we go on there and go get our digital stuff from there.
Awesome.
So I got a counter question for that, because yes, because we went to school, we all know cite your sources. Got to be peer reviewed. It's got to be a scholarly source. We know that. But to counter that, as far as how Black people don't trust the medical community and don't trust, how do we then combat it when somebody says, yeah, but even your scholarly sources are biased? You do realize that your sources might not have researched everything thoroughly. It might have the answers, but it has its limitations, especially when it comes to Black and brown people.
I can answer that.
I can answer that too. I can answer that too. Go ahead, Shad.
That's why you get peer reviewed. So it's not just like one person just writing an article and then they're like, this is all my research. Peer reviewed is like multiple people looking at the sources and actually dissecting and going through that. And I mean, honestly, for every shred of evidence, you're always going to have the counter evidence, right? So that's why you kind of go through all peer reviewed articles.
And I'll add to it.
For like the general public, though, you can't be like, oh, but this article is peer reviewed and reviewed by X amount of people. They're gonna be like, I don't care.
I don't know them people.
Right. To add on to it, and for the audience, the average person, that's why we're all doctors, because the average person does not know how to read a research article. They can't tell you what exactly is in that research article because they don't know how to read it. And that's no shade. It's just saying that we actually are trained to do that. Master level, doctorate level up, we're trained to read those things. We know what is a counter argument and limitations. In addition to being peer reviewed, there's going to be that opposing, like Auntie Shook said, there's going to be that opposing argument. And if you go looking for it, it'll be there. And then that is when you talk to your professional and discuss those things. So the average person doesn't know how to read.
And just to piggyback off of that. So yeah, when I do have clients that I don't, Google is okay as long as you know what resources you're looking at when you're looking at Google, because Google's going to give you like the top 3 things and it has the drop down questions, and people tend to just read like the first 2 sentences and they go with that. But I do like recommend that, like, if you're not able to read a full research article and you don't know what you're looking for when you're looking at the sample size and what demographics are in the sample and all of that, then at least make sure that the resources that are used in whatever article that you're reading are valid resources. So usually those are peer-reviewed resources, but you can check that too, because it is helpful for the general public to read like an article that's a summary of these 5 different research studies, right? Like it's more digestible. But just make sure that the research they are using, when you look at it, it says something about scholarly or peer-reviewed articles. And then you can use that, that's a little more, I can't think of the word, but it's a little bit better than just looking at the pop-ups on Google.
Yeah, and then another thing too is like,
so as far from the mental health standpoint, I was discussing as far as how we aren't taught how things look in minorities, how, different diagnoses and all sorts of things. Do they teach you all that, or is this just from experience that you've noticed that, okay, depression shows up a different way, anxiety shows up this way, or is it being a Black woman or, being raised in a Black family, like that you just can relate and you use those things to help with your diagnosis?
That's a good question. I can answer as far as like looking into like peer-reviewed articles, other articles, especially pertaining to our Pacific populations that we work with, keeping up with that research. And yes, Black women do, Black people in general tend to present very differently when it comes to mental health. Same with Hispanics, same with the Asian population, the Native American population. They all present very differently. Let's just say ethnic communities, cultural communities tend to present very differently. And so I don't want to say, at least in my experience, we wasn't necessarily taught that, I would say, but there might have been little bits, put in there. But as far as our extended research, at least my extended research, I had to go more in depth to look that up based on the population I work with.
I agree.
yeah,
I have to look for myself. I distinctly remember my theories class in school, in my master's program. In the counseling theories class, at the end of each theories section, it was a section that said cultural limitations. And it broke down like, this might present differently in African Americans, or this might look like this. It was a little, like, I swear it was a paragraph out of the whole chapter. So if you wanted more, like, okay, you're telling me it looks different, but how does it look different? You got to do that research on your own. Like, that's on your own time. We ain't going that far into it. So a lot of things we have to kind of seek out the source in the research on our own.
and some of it, and like if you had to take like multicultural competencies and stuff like that, sometimes they did go a lot deeper into culture. I didn't find that in my master's program so much as I found it in my doctorate program, because once you start getting into psychology, they're trying to break everything down bare bones. Now, they obviously don't always get it right because it wasn't necessarily created for us, but and I won't say don't get it right. They get some things right, but they don't go super, super in depth. So what we did have a lot of is we had a lot of Hispanic people, we had some Asians, we had African Americans, and so we kind of all chose, like, I noticed that whenever we chose to write our dissertations, we all chose like FUBU, like, I'm writing this for us by us. And so then we had to do a lot of extra research. I found out while writing my dissertation stuff about Black people I didn't even know. And like, just like, look, like even with the Black LGBTQ community and stuff like that, like, I know a lot from my perspective as a Black woman, but I don't think typically thought of, man, superwoman syndrome could be a sign of depression. I never had to think of it like that because I have superwoman syndrome. So I think just challenging yourself to go a little bit deeper, because those books ain't gonna take you as deep as you need to go. They're gonna give you whatever they can, but I think it's up to us to go deeper, and it's up to us to educate further.
I agree with that. I think that, like Auntie Shug said, I didn't start learning more about like the multicultural perspective until I was in the doctorate program. But there is one book in particular that I still reference, and I don't know the name of it, but I know the author's last name is Sue. And that book literally breaks it down in like different minority categories, what certain diagnoses can present as. I actually have referenced it. I had a Korean client at one point, and I was completely lost as to like how to diagnose or what was going on. And that book was extremely helpful. So there are certain books that go into a lot of detail, and then other times it's more of like your professors are like touching on it, but then it's like, yeah, cultural here, and then like you move on from that. So they aren't necessarily teaching you that, but if you actually read the resources and do the work for yourself, like Auntie Shook was saying, then yeah, you'll get something out of it. But I remember my question now. So it was about this is like countering what you were asking, mental health in your setting, in the medical setting. I know that I have, like, when I was pregnant, I had to take screeners for like postpartum depression and things like that. But do they teach you all like what the signs and symptoms are for certain mental health diagnoses, and like when it's appropriate to refer out or refer them for an evaluation or for therapy? Is that something that's that you learn as you go, or is it something that's actually taught to you in school?
So during school, we go through a psych block. And so you learn about depression, anxiety, and if that's something that you want to be a psychiatrist or something that you want to like really dive into, you can go further down that pathway. Other than that, we just kind of use it like, oh, okay, we learned this. We'll have an exam on it, and you kind of just put it in your pocket for later. I would say in during training, so we screen for depression, postpartum depression during like the history and physical part. You kind of dive into their past medical history of depression. Um, but I would say you're not really taught well as far as when when have you reached, your peak of therapy and you need to pass this patient along. And honestly, where I am, we don't have a lot of resources. So it's like, okay, you diagnose this patient with depression. Oftentimes, seeing a therapist is not covered by insurance, if covered at all. And, always that financial barrier to healthcare or, any type of therapy, like it's real. And so if I had to choose between going to see a therapist and providing over, my kids' head or food, like I'm gonna absolutely choose my family. And so a lot of people are just walking around with these diagnoses untreated just because they don't have the resources to get help.
So I'm gonna pivot a little bit here. I mean, we kind of touched on a little bit, but I want to go a little bit deeper. So, oftentimes when we talk about racial bias in the medical field, and specifically Black people, people of color's mistrust and distrust of the field, we are looking at it from the lens of white doctors, right? Or specifically white doctors. But I want to ask you what your thoughts are on other doctors of color, Black doctors and other doctors of color who are also extremely biased. They tend to follow the same path. There was a specific doctor, a woman, Black woman, who made a statement. She's on one of those Married to Medicine shows or something like that, and she made a specific statement, and she took backlash from it, where she said, well, yeah, Black, she's an OBGYN too. She said, well, yeah, like when some Black clients come in, that they just complaining. They just there to complain. There ain't nothing wrong with them. You gotta send them on their way. And people were pissed. They were like, are you a doctor saying this? Like, it's been Black women step in your office that you don't believe. And she's like, I didn't mean it like that, but it was too late. It was too late to put it out. So that brought up for a lot of people like that whole concept of false kinfolk and kinfolk, but to see that from your own can be a struggle. So have you encountered that yourself?
I mean, I have never personally seen this, but when I do see things like this, especially when it's pretty much globalized because of the media and those sorts of things, it takes us so many steps back. Like we already dealing with issues of trust, and I mean that's definitely a smack in the face. And it's kind of like, yeah, told y'all so. Like they don't care. This is somebody that looks just like me, and they don't care. So it really just adds more fuel to the flame in a bad way.
Just one more question for me. I know we're kind of getting ready to wrap it up. Do you see like it's ethically responsible for us to see some pro bono clients? I ain't gonna ask like, do you see a certain amount of Black pro bono clients? But do you see pro bono clients? It feels like the medical field is be raping people's pockets instead of um, doing no harm and seeing everybody that they can.
So by law, we have to see everybody, and that's more so, MTELA. If you come into the ER, like I can't ask you, hey, do you got money in your pocket? You got insurance in order for me to treat? And people ask me about insurance and payments all the time. I have no idea what we are paid. I have no idea what insurance covers. I don't know what my insurance covers. I recently had to use my insurance, and I was just like, "Where's my card? And what am I allowed?" Like, I have no idea. And me as a hospitalist now, I work for a hospital. I definitely don't know what's charged, but I'm sure we cover anybody that walks through the door. So I don't have a specific number, but yes, we care for everybody.
Okay, so you wouldn't know, like, even if they don't have insurance, is like you still have to like take them, or you don't know if they're getting like this big gigantic bill in the mail or anything like that.
So
Like that's not
I'm
your
sure
your.
they're charged. I'm sure they're charged. But I know the hospital writes a lot of stuff off. Or I think last month I had seen a post where, medical debt is the highest debt for most Americans. Like, you kind of just die with it. It's kind of like, all right, it's growing back there, whatever it is, what it is. So
I just got one more question myself, more so on your own experience personally. Um, what has your experiences been like as a patient? Because you're a doctor. So to now go see a doctor as a doctor, do you find that do you even tell them you're a doctor? Do you get treated differently when they know you're a doctor? How does that look for you as a patient?
since I've been a physician, I feel like probably I get care from my colleagues, and so they know that I'm a physician. But I think if I went somewhere else, it has somewhere that I'm a doctor, because you can tell there's just a little more empathy. Um, but I would say, I'm kind of a secret shopper when I go with my dad to some of his appointments, and I definitely have sat back and let them just talk over his head, and I'm just like, "Are you going to explain like what these medicines are, what the procedures are?" And then they just kind of start looking like, "Okay, this person might be in the medical field because they're like speaking my lingo." And a few times I've had to tell them like I'm a doctor, and you can tell like a switch kind of turns on. They're like, "Oh, wait," and I'm like, "It's too late. You've already shown who you are." But I mean, you really just got to be careful of like who you're in the room with. And my nurses would always tell me that my treatment was different. And I'm like, how? I just treat people how I feel like they should be treated. If you call this VIP treatment, everybody's VIP to me, because there would be some providers where you would have to tell them, like, oh, this is, the CEO's wife, or, she's a doctor. And, I guess they would like turn on a different type of care. I don't know how that looks, but I mean, it's definitely a thing. And I don't think that should be going on. Like, everybody should be VIP that walks into your door. Or, I treat them like family. Like, how would I want my mom, my aunt, my sister to be treated if she was sitting in front of me? But I would ask, as far as on your end, our biggest issue right now is trust, as far as people seeking out care. What are, I guess, the barriers, or what's stopping minorities from accessing like mental health care?
Same. Trust. Mm-hmm.
Stigma, access.
Finances, insurance, all the same things. They don't trust mental health either. For a lot of people, mental health and medical health are conjoined. They're not separate things. They don't even like when you tell somebody, people in the in the world don't know what the letters mean behind our name. So they don't know. They see a letter, they're like, "Oh, you a doctor?" I'm like, "No, not yet. I'm not." So you have to really like get people to trust you, and that's hard to do. But finances and insurance, we deal with the same thing.
Are minorities treated differently, or have you seen that? Like,
I'll be honest. Some people are in their own way, and it's not always other people that are holding them back, or insurance that are holding them back. Some people don't go get their mental health treated because you can't see mental health. I can't see depression. If my leg is broke, I can't hobble into work. I need to go get my leg fixed. But if my anxiety is breaking me down, I'm not going to go get that fixed because I still need to work, and nobody can see that. So people also like to hide.
I think the stigma is a big thing. For a long time, I don't even know when it started to change, but for a long time, insurance only covered medical treatment, like doctor's office, and mental health care wasn't included in that. And there was also a stigma at the time, like if you needed mental health care, like you're crazy or like something's wrong with you. So that stigma has carried over the years. And I am thankful that they have kind of changed and like merged it to where mental health care is covered by insurance. And I have noticed that I have started to see a lot more people of color in my office, which I love to see, because they are now starting to learn like I can access this through insurance. A lot of insurances now, they do cover therapy, they do cover psychological evaluations, they do cover certain like supplemental treatments like occupational therapy, speech therapy, ABA therapy. So a lot of things are covered under insurance, but sometimes people don't know, or there's a long wait list and they can't get to it.
And
So
I will say also, Emery, I don't get treated different going into mental health. So when I go to therapy myself, but when I did go to therapy, I was treated just like the bare bones therapy patient. Later on, somehow it came up that I was a clinician. My therapist, she's a white woman. She was like, "Why wouldn't you tell somebody you was a therapist?" And her level of care didn't change. She actually had higher expectations because now she was like, well, you know what you're doing. So you know all this stuff and you're not doing it. So let's get to the point of breaking you down back to bare bones, treating you like a regular patient, and then making you rise up to what you already know to do. And so I think I was easier to treat. And she actually liked that because it's like now I don't have to talk to you like just a regular patient. Now we can actually talk for real and we can move your healing forward.
Two things I didn't like what my therapist did. I did not like when my therapist would say, "Well, you a therapist, so I can, you know this stuff." I'm a human though. My job and what I learned at school ain't got nothing to do with my everyday human being life. I hated that. I switched therapists because of that. Because don't think just because I'm a therapist and I do know these tools, that don't mean nothing. Baby, I still have issues. I still got anxiety. I got these kids. That don't matter. Don't so treat me like a regular client, not like I'm a therapist and I somehow know more or know these tools. I, with my therapist.
I think church also plays a part of mental health. That was always the solution, but I think that now it's been kind of they're working in conjoint, like they're working together now. Instead of it being okay, well, just go to church, just pray about it. I think now it's starting to shift. Like, okay, you can have God and a therapist, and so I it's really good to see that shift.
That was my last one. The insurance thing. Yes, insurance does cover mental health more now, but the thing with mental health, and people don't like when folks say this, I'm self-paying, right? So I can pretty much see anybody. No matter what their diagnosis is, I can see them. With insurance, you got to have a billable diagnosis. It's not just, I just need to see somebody because I'm going through. No, I got to be able to diagnose you with something that's billable for your insurance to cover that. And insurance still doesn't cover like couples counseling. So if you're having a traumatic time in your relationship, well, I'm sorry, insurance not covering couples counseling. So insurance.
there are insurances that do cover couples counseling, just to say that.
Oh, none of the ones the office I worked at took then. None of them people could get covered. But yeah, so insurance is a barrier sometimes because of that, because you do have to have that. And that's one thing I like about the medical field. At the end of the day, if you have insurance, you know at least you can go in for your yearly wellness check, right? Once a year, you're gonna go see your doctor. That's not the case with mental health. It's not like, oh, once a year, go get your mental wellness check. It's like, no, you got to have a diagnosis, and that's when we gonna cover.
Yes, there is. Once a year, you go get your mental, that's called a psychological evaluation, and your insurance will cover it once a year. If your insurance covers it, it is
I'm gonna look that up.
once a year.
Well, ain't nobody coming to me for a psych eval because I don't do testing.
No, but I'm just saying, as far as like, if you're thinking like comparing it to like medical health and like getting your checkup, that would be the equivalent of that. And insurance does cover that once per year fully. Most insurances.
Do you all see anything specifically that your field is doing to like bridge this gap, this like these racial bias gaps?
I not particularly. So I do things to bridge the gap. Like I did like in Black History Month and stuff like that. I did like education of my coworkers. And I use a lot of mental health education in there. And I had one clinician come back and he's like, "Oh my God, like the stuff that I learned about other cultures is just it's enormous. Like there's so much that he didn't know that he actually studied." So I think right now At least as far as I know, it's on a micro level.
Yeah, that's exactly how I feel. Like if you can change one person and let that ball roll, like, all right, I'm making a difference.
I can
Yeah.
say from a systemic level, when it comes to licensure, I've been advocating a lot at the state about getting more clinicians of color in Pacific neighborhoods or in Pacific agencies, because a lot of minorities want to come to see therapists, but they can't find anybody who looks like them. And because we're in psychology, it's even less. We're only 5% of total psychologists in the country as Black women. Actually, as Black people, 3% as Black women, 2% as Black men. So I think advocating on a systemic level to put more clinicians in place to help bring those people into therapy.
That's what I was gonna say. I don't see so much of like the field doing something about it, but I see more of us trying to get into the field, because that's part of why the racial bias is there, is because it didn't start out with us. Like a lot of us didn't, like we weren't doing the work, we weren't doing the treatment. And now a lot of us are trying to get in. You're seeing more Black psychologists, more Black counselors trying to get in and do this treatment and help out our community as well as the other communities. But just us being there and having the face and being the representation, I think that is part of how we're starting to bridge the gap as well.
Yep. And we have, like me, I try my hardest to find the Black mental health professionals out there who are putting things out that can kind of bridge that gap. Like there is now a DSM of color by a psychiatrist, a Black psychiatrist, and it's like pre-order. And it was, she hasn't put it on pre-order yet. I'm like, soon as she drop it, I'm buying it, because I'm interested in things like that, like reading things like Decolonizing Therapy, which is by a black doctor. Those are the ways that I see us doing it on a micro level. We're trying to get people to understand and to see how it affects us. And then, of course, the clinical cookout, we doing it too. This is our way to try to bridge that gap. Like, we're trying to give education and awareness. We're trying to make it where it's accessible. Everybody seems to have social media, will use social media to actually learn something. So we're doing it, but on a micro level.
Yeah, I would say it's the same with us. You know, the people are in the trenches. Like we got to just keep fighting. You know, a day at a time. Um, there all have been like bundles and different protocols that have also been rolled out, at least for us as obstetricians, where if you start this protocol, you're treating something by the number or by the symptom. You're not looking at who the person is or where they're from, socioeconomic status. None of that. It's like, all right, if you met a criteria for a blood pressure, you will be getting these treatments until that blood pressure comes down. And we are starting to see a difference with some of those protocols being rolled out.
Okay, so Dr. Butler, thank you so much. This has been so informative. And I know for sure that there are so many people in our community that's going to look at this and they're going to be so happy that we did it, because a lot of people have questions and they don't have anybody to answer them. And then honestly, I'm going to be 100% honest with you. Growing up, I seen one Black doctor, just one. And he wasn't, he might have been an OBGYN, but I seen one Black doctor that was an OBGYN. So that's what made me aspire to be that. And so just thank you for being the face for our girls. I see that you are a Delta Sigma Theta sorority member. Okay. I love that. And I think we just need more people like you. We need more people like you to express to our community that they can do it. Yes. And to break down these stigmas, excuse me. So with that said, we got y'all some free mental health. We talked to Dr. Butler. Go and get your OBGYN, and you might be able to find a Black woman. So my only question to y'all is, what y'all about to do?
Guess what, y'all? The in-person clinical cookout is coming to a city near you, and that city specifically is Cleveland, Ohio, on July 13th, 2024. So get your tickets, get registered, and we'll see you there.
Yes, and we are doing a mental health conference and we are doing a clinical cookout. So you don't want to miss either. The mental health conference, we are all presenting as the Aunties. I'm talking about psychological evaluation, what that looks like for the minority community.
Auntie Keisha is going to be talking about how do we reach our kids in a way that's good for both the parent and the child.
Auntie Sugar is going to be talking about trauma. Y'all know I love trauma. Let's talk about our childhood trauma. Let's talk about how we pick all our trauma up and bring them into these relationships. And that's relationships with your kids, your spouse, your family, your friends, your church members, everything. Let's unpack our stuff so that we're not dumping it all over everybody else.
And Auntie Ashley is going to be talking about all those relationships Auntie Shug just mentioned, but from a womanist lens and how we can better our relationships if we take some things from that frame. Don't forget to tell people now. Y'all, it's free. There is no excuse. The registration is free. You're gonna get free food and free mental health. So come on. Oh, and just know, if you by chance cannot make it out to Cleveland for the in-person clinical cookout, but you still want to support the clinical cookout in order for us to help support the community, you can always donate. We have a donation button available on our website, and you can go and click on it and just pour your money into something positive.
Hey y'all, so the aunties know there are tons of card games out there, but none quite like this. Auntie Ashley wants to know, in what ways have you been the villain in someone's story? Auntie Shug wants to know, what is your biggest insecurity about your body and why? Auntie Keish said, if you could complete a greatest hits album with all the songs that lift your mood, what would it be? And Auntie Amber is wondering, when have you put on a mask to conceal your feelings, and how did this affect you long and short term? Our new clinical cookout conversation cards are meant to be a fun, interactive game that helps to deepen your relationships with family, partners, and friends. And with that objective, everybody wins. Pre-order for the clinical cookout conversation cards is available now, so go on and get you some for your next cookout.